Hi, welcome back to your prescription for medication education. My name is Emmy, and I'm a pharmacist, and I like to talk about medications. And if you'd like to learn about them, then I think this is the right channel for you. Today I'll be talking about beta blockers and their use in hypertension. So I'll just go ahead and begin. I like to start off my videos with a couple of questions just for fun. At the end, I'll go ahead and provide the answers. Question number one, a patient taking metoprolol tartrate is started on paroxetine for depression. 2 weeks later, he presents with fatigue, dizziness, hypotension, and marked bradycardia. Which explanation best describes this interaction? Is it A, paroxetine induces CYP2D6, lowering metoprolol levels? B, paroxetine inhibits CYP2D6, increasing metoprolol exposure? C, paroxetine blocks beta-2 receptors, causing unopposed alpha-1 activity? D, paroxetine inhibits P-glycoprotein, increasing metoprolol absorption? Or E, paroxetine reduces renal clearance of metoprolol? Question number two. A patient with type 2 diabetes takes glyburide and is started on propranolol for tremor. Which counseling point is most appropriate? A. Propranolol may make hypoglycemia feel more intense by increasing tachycardia. B. Propranolol may mask tachycardia and delay recovery from hypoglycemia. C. Propranolol prevents sulfonylurea-induced hypoglycemia. D. Propranolol increases insulin secretion and lowers glucose predictability. Or E. Propranolol has no clinically relevant effect on hypoglycemia awareness. And the last question, question number three. A 59-year-old patient taking propranolol reports cold fingers that become pale and numb when exposed to cold temperatures. Which mechanism best explains this effect? A. Increased beta-2 mediated peripheral vasodilation. B. Loss of beta-2 mediated vasodilation with relatively greater alpha-mediated vasoconstriction. C. Increased nitric oxide production through beta-3 stimulation. D. Direct activation of vascular smooth muscle potassium channels. Or E. Increased renin release from the kidney. Let's do a quick refresher on adrenergic receptors to better understand how beta blockers work. Adrenergic receptors are G protein coupled receptors that are activated by catecholamines such as norepinephrine and epinephrine. They can be divided into two major families, which are alpha and beta receptors. Within the beta receptor family, there are three major subtypes: beta 1, beta 2, and beta 3. All three beta receptor subtypes mostly couple to GS proteins, which stimulate adenylocyclase and increase intracellular cyclic AMP. Beta 1 receptors are highly expressed in the heart as well as the kidneys. Activation of beta 1 receptors in the heart produces positive chronotropic, ionotropic, dromotropic, and lusitropic effects. In the kidneys, beta 1 activation stimulates renin release. Beta 2 receptors are found in several smooth muscle tissues, including our lungs, GI tract, genitourinary system, uterine smooth muscle, and vascular smooth muscle. They are also found in skeletal muscle as well. Activation of beta 2 receptors causes vasodilation, bronchodilation, and tremors. Beta 3 receptors are mainly found in adipose tissues and in the bladder. In adipose tissues, beta 3 receptor activation can promote lipolysis, especially during increased adrenergic stimulation. In the bladder, beta 3 activation relaxes the detrusor muscle, which increases bladder storage capacity and reduces urgency and frequency. Beta blockers competitively antagonize catecholamine binding to beta adrenergic receptors, which inhibits the downstream GS protein coupled signaling. This translates to a decreased sinoatrial node automaticity, decreased myocardial contractility, slowed AV nodal conduction, and decreased renin secretion from juxtaglomerular cells. The antihypertensive effects of beta blockers is multifactorial and not completely understood. Contributing mechanisms include a reduced cardiac output due to decreased heart rate and contractility, as well as suppression of the renin-angiotensin-aldosterone system through reduced beta 1 mediated renin release, which can lower downstream angiotensin II and aldosterone signaling. Additional proposed mechanisms include central sympatholytic effects and resetting of baroreceptors. Chronic use may reset baroreceptor sensitivity, which may help maintain blood pressure at a lower set point over time. Most of the evidence for beta blockers in uncomplicated hypertension is dominated by atenolol. Compared with other first-line antihypertensive classes, traditional beta blockers appear to be less effective for stroke prevention, particularly compared with calcium channel blockers and RAS inhibitors. They may also be associated with slightly higher all-cause mortality compared with calcium channel blockers, while showing no clear reduction in all-cause mortality or coronary heart disease compared with placebo. One proposed explanation is the central pressure hypothesis. Traditional beta blockers slow heart rate, which may allow reflected pressure waves to return during systole and increase central aortic pressure despite lowering brachial blood pressure. This was shown in the CAFE sub-study where atenolol lowered brachial blood pressure similar to amlodipine, but atenolol resulted in a smaller decrease in central aortic pressure. Vasodilating beta blockers such as nebivolol and carvedilol may lessen this effect by reducing central pressure augmentation. However, no large randomized outcome trials have shown that vasodilating beta blockers are superior to non-vasodilating beta blockers for hard cardiovascular outcomes in uncomplicated hypertension. The 2025 AHA-ACC guidelines maintain that beta blockers are not recommended as first-line agents for uncontrolled hypertension, reserving them for patients with compelling indications such as coronary disease or heart failure. Both the VA, Department of Defense, and a JAMA review concur that beta blockers should be reserved for patients with compelling cardiovascular indications. There is some positive evidence from observational studies with nebivolol in regards to reduction in cardiovascular events, but again, these studies are not based on randomized outcome trials. Beta blockers are classified into 3 generations based on receptor selectivity and additional pharmacological effects. Examples of first-generation beta blockers include propranolol, timolol, sotalol, and nadolol. These are considered non-selective, meaning they antagonize both beta-1 and beta-2 receptors with about equal affinity. Examples of second-generation beta blockers include metoprolol, bisoprolol, atenolol, and esmolol. These are relatively beta-1 selective, but this selectivity is dose-dependent and diminishes at higher doses. Examples of third-generation beta blockers include nebivolol, carvedilol, and labetalol. These agents have varying beta receptor selectivity, but their defining feature is vasodilatory activity. First-generation beta blockers are non-selective, meaning they block both beta-1 and beta-2 receptors. Because beta-2 receptors are found in bronchial smooth muscle, peripheral blood vessels, skeletal muscle, liver, and pancreatic beta cells, these agents have a higher risk for bronchospasm, peripheral vasoconstriction, and metabolic effects compared with beta-1 selective agents. In patients with asthma, non-selective beta blockers can worsen bronchoconstriction by blocking beta-2 mediated bronchodilation. Propranolol has been associated with clinically meaningful reductions in FEV1 and a higher risk of asthma attacks compared with placebo. Cold extremities or Raynaud-like symptoms can occur due to a loss of beta-2 receptor-mediated vasodilation in blood vessels in the hands and feet. This may present as numbness, tingling, cyanosis, or color changes. Beta blockers can also affect glucose metabolism through several mechanisms, including impaired insulin secretion from pancreatic beta cells, increased peripheral insulin resistance, altered hepatic glucose handling, and impaired responses to hypoglycemia. These effects are most noticeable with older non-vasodilatory agents and have been associated with an increased risk for new onset diabetes. The blunted response to hypoglycemia is critically important, especially for diabetic patients on insulin and sulfonylureas. Beta-1 blockade can mask tachycardia that serves as an early warning sign of hypoglycemia, leading to hypoglycemic unawareness. Beta-2 blockade in the liver and muscle can impair epinephrine-mediated glycogenolysis, which delays glucose recovery. And on rare occasions, a hypertensive crisis may occur because of catecholamine release, triggered by hypoglycemia produces unopposed alpha-1 adrenergic stimulation. Second-generation beta blockers have greater affinity for beta-1 than beta-2 adrenergic receptors, which translates to a more pronounced effect on the heart and kidneys while minimizing beta-2 mediated effects in the bronchioles, peripheral vasculature, and metabolic tissues. It's important for me to emphasize once again this beta-1 selectivity is dose-dependent and diminishes at higher concentrations. Bisoprolol is considered the most beta-1 selective agent amongst the second-generation beta blockers. Metoprolol is the most widely prescribed beta blocker, and for this reason, I'll give it some extra attention on this slide. It's available in two formulations, which are metoprolol tartrate, which is an immediate release formulation, and metoprolol succinate, an extended release formulation. The immediate release formulation has a short half-life of about 3 to 4 hours and is often dosed twice a day, which can result in peak and trough fluctuations, which can result in periods of excessive blockade, alternating with inadequate coverage. Its FDA-approved indications include hypertension, angina, and acute myocardial infarctions. The succinate version was designed to provide more consistent beta blocker coverage over a 24-hour period due to its controlled release mechanism. Its more stable plasma levels enhance cardioselectivity, which limit high peak concentrations that can cause beta to spill over. It's approved for hypertension, angina, and heart failure. Metoprolol succinate is the formulation with heart failure with reduced ejection fraction mortality data, showing reduced cardiovascular mortality and heart failure hospitalization. Metoprolol is moderately lipophilic and undergoes extensive hepatic first-pass metabolism, significant CNS penetration, and is mostly metabolized by CYP2D6. CYP2D6 genetic variation can substantially affect exposure. About 8% of Caucasians are poor metabolizers, which experience about 5-fold higher plasma levels compared to extensive metabolizers. A meta-analysis of 15 studies found that poor metabolizers had an additional 3 beats per minute reduction in heart rate and a 4-fold higher risk for bradycardia compared to non-poor metabolizers. Esmolol is an IV-only, ultra-short-acting beta-1 selective beta blocker with a half-life of about 9 minutes due to rapid hydrolysis by red blood cell esterases. Esmolol's metabolism is independent of hepatic and renal function, making it a useful choice in patients with organ dysfunction. Third-generation beta blockers are different from earlier beta blockers because they have additional vasodilating effects. This means they not only block beta receptors, but also help relax blood vessels. This may help overcome some limitations of older beta blockers, such as less reduction in peripheral vascular resistance and less favorable effects on central aortic pressure. Carvedilol and nebivolol are both vasodilating beta blockers, but they work through different mechanisms, so they should not be considered pharmacologically interchangeable. Carvedilol blocks beta-1, beta-2, and alpha-1 receptors. Its alpha-1 blocking effect causes arterial vasodilation, which lowers peripheral vascular resistance and afterload. Carvedilol also has additional properties that may contribute to its cardiovascular benefits, including antioxidant activity and beta-arrestin-mediated signaling. Its antioxidant activity is related to its carbazole structure, which is unique among beta blockers. Carvedilol is highly lipophilic and undergoes extensive first-pass metabolism, giving it a relatively low oral bioavailability. It should be taken with food to slow absorption and reduce the risk for orthostatic hypotension. While second-generation agents increase new-onset diabetes risk by about 18 to 32%, carvedilol has been associated with a 10% decrease in new-onset diabetes incidence and a 22% lower incidence compared with metoprolol in heart failure patients. Nebivolol is highly beta-1 selective and is considered one of the most beta-1 selective beta blockers available. Unlike carvedilol, nebivolol does not rely on alpha-1 blockade for vasodilation. Instead, it promotes nitric oxide release through endothelial nitric oxide synthase activation, largely involving beta-3 receptor signaling. This nitric oxide effect relaxes blood vessels and may improve central pressure dynamics. Nebivolol is also considered metabolically neutral with less adverse effects on insulin sensitivity and lipid metabolism compared with older non-vasodilating beta blockers. Labetalol is also sometimes classified as a third-generation beta blocker because it blocks both beta and alpha-1 receptors. However, it is not the same as carvedilol or nebivolol. Labetalol is non-selective at beta receptors and produces vasodilation mainly through alpha-1 blockade. It does not have the same nitric oxide-mediated effect as nebivolol or the same antioxidant properties as carvedilol. Clinically, labetalol is especially useful for hypertensive emergencies and pregnancy-related hypertension because it is available intravenously and has a rapid onset. It is not typically used as a chronic heart failure beta blocker. Bradycardia and conduction disturbances are the most clinically significant beta-1 mediated adverse effects. Beta-1 blockade in the sinoatrial node suppresses automaticity, while beta-1 blockade in the atrioventricular node slows conduction. This can lead to bradycardia, AV block, dizziness, fatigue, or syncope. A Japanese adverse drug event database analysis found that bradyarrhythmias with oral beta blockers often followed an early failure pattern, meaning the event tended to occur soon after treatment initiation. In this analysis, bradyarrhythmias typically occurred within the first 2 months of treatment. Beta blocker withdrawal is a well-known consequence of abrupt discontinuation after chronic beta-1 blockade. Abrupt discontinuation leads to beta-adrenergic receptor upregulation and supersensitivity. This can result in tachycardia, hypertension, sweating, tremor, and palpitations, symptoms that can mimic thyrotoxicosis. Discontinuation of beta blockers has been associated with a four-fold increased risk of coronary events in hypertensive patients and increase in hospital mortality in heart failure patients. For this reason, gradual tapering over 1 to 2 weeks is recommended for all agents. There is conflicting evidence regarding beta blocker side effects such as depression, fatigue, and sexual dysfunction. A landmark JAMA meta-analysis of 15 randomized controlled trials involving more than 35,000 patients found that beta blockers were not associated with increased depressive symptoms compared with placebo. However, they were associated with a small but statistically significant increase in fatigue and sexual dysfunction. Approximately 1 additional fatigue report per 57 patients per year and 1 additional sexual dysfunction report per 199 patients per year. Fatigue was reported more often with early generation agents than with later generation agents. However, a large 2025 Danish nationwide cohort study of over 200,000 patients found that in real-world practice, beta blocker initiations was associated with higher rates of depression compared to calcium channel blockers, but not higher rates of erectile dysfunction. Because this is considered observational data, the findings show an association rather than definitive causation. CNS side effects, including vivid dreams, fatigue, sleep disturbance, are more common with lipophilic agents such as metoprolol and propranolol because they cross the blood-brain barrier more readily. However, when beta blockers are used at similar therapeutic doses, the real-world difference in quality of life side effects between water-soluble and fat-soluble agents may not be as large as traditionally thought. I've listed several beta blocker drug-drug interactions here, but I won't cover every single one in detail. For the sake of time, I'll focus on a few examples. First, combining non-DHP calcium channel blockers with beta blockers can produce additive, negative, chronotropic, dromotropic, and ionotropic effects. Clinically, this can present as excessive bradycardia and high-degree AV block, hypotension, or worsening heart failure. Verapamil may also add a pharmacokinetic component to the interaction by decreasing the clearance of metoprolol and propranolol. Metoprolol, carvedilol, nebivolol, and propranolol are all CYP2D6 substrates. Strong inhibitors such as paroxetine and fluoxetine can increase exposure significantly. For example, metoprolol concentrations may increase by as much as 8 times. Moderate inhibitors such as amiodarone and mirabegron can increase exposure with some reports stating up to 2 to 3 times. A Medi-Cal cohort study found that patients receiving moderate to strong CYP2D6 inhibitors with beta blockers had a 53% higher risk of hospitalization or ED visits for hemodynamic events. Beta blockers may blunt epinephrine efficacy during anaphylaxis by antagonizing beta-mediated cardiac stimulation and bronchodilation. Patients taking beta blockers may have less predictable responses, which may make standard doses ineffective during anaphylaxis treatment of epinephrine. If anaphylaxis is refractory to epinephrine, glucagon may be considered because it increases intracellular cyclic AMP through a non-adrenergic pathway. And finally, beta blockers and digoxin both slow AV nodal conduction and heart rate, creating an additive risk for bradycardia and heart block. Carvedilol can also inhibit P-glycoprotein, which may increase digoxin concentrations by about 15 to 20%. So monitoring for digoxin toxicity and bradycardia is important when these agents are used together. And the answers to the questions at the beginning of the video were 1 Bravo, 2 Bravo, and 3 Bravo. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider giving me a like and subscribing. Thank you and have a great day.